Okay, good evening, everyone. I think we'll get started. It's a pleasure to welcome everybody to tonight's lecture. Before I get started and introduce today's speaker, I want to remind everybody this is the Fralin Biomedical Research Institute Maury Strauss Distinguished Public Lecture Series. And again, before I introduce tonight's speaker, I want to put in a plug for the next speaker in the series. That'll be Thursday, November 4th, same time. And that speaker will be Dr. Mark Batshaw. Dr. Batshaw is a senior investigator at the Center for Genetic Medicine Research at Children's National Hospital, Washington, D.C. He's also a professor of pediatrics, George Washington. And he's the former CAO at Children's National, who really built that place into a major pediatric academic medical center and powerhouse over the last 2 decades. He'll be talking about travels around the urea cycle. So I hope to see you all for the next one as well. So without further ado, and just to remind people about the ground rules, if you have questions, please put them in the Q&A, not the chat, the Q&A, and then I will read them out to the speaker at the end. So go ahead and type your questions into the Q&A anytime you have them, okay? All right, so it is a truly great pleasure to welcome Dr. Roberta Schwartz from Houston Methodist Hospital in Houston, Texas. Dr. Schwartz is the Executive Vice President and Chief Innovation Officer at Houston Methodist. By way of background, she did her undergraduate work initially with an undergraduate degree in psychology at Columbia Barnard College. She spent a year at Oxford University and then went on to do her master's in public health at Hopkins School of Public Health. She began her work career after that working for APM Computer Science as a senior associate, providing strategic planning input to improve healthcare delivery at academic medical centers. And then from there, she worked at Mount Sinai in New York at the School of Medicine, where she was director of business development, and she grew the clinical enterprise, the School of Medicine, and the faculty practice plan. And then she joined Houston Methodist in 2001, where she's been since. But meanwhile, when she was there after a few years, she went back to pick up her PhD at the University of Texas in healthcare policy and administration as well. Dr. Schwartz has been recognized in many ways. She's an elected fellow of the American College of Healthcare Executives. She also received their Regents Award. She's been involved with Medicaid program development as an officer. She was a healthcare fellow with Senator Paul Wellstone on residency education and healthcare reform. And then she worked in the Center for Medicaid and Medicare Services in the Office of Legislation and Policy, where she advised on policy issues for healthcare for special needs populations. She has played a key role at Methodist in many major initiatives, including just a couple, forming Methodist Hospital's Research Institute, the growth of the transplantation programs there, and planning Methodist Outpatient Center. She truly has been an architect of the Houston Methodist Center for Innovation and really focusing on digital information to improve patient and physician experiences, including the use of telemedicine. And she's not just doing all these things in her leadership role there, she's actually doing the academic side, has published a series of papers, and if you live in Houston, you appreciate this, including how to brace for a major hurricane in terms of a health system. And having lived in Houston myself, I know what that's all about. And implementing telehealth during COVID, and also developing a COVID employee vaccine policy, an area I think of great interest to folks here. So without further ado, it's my great pleasure. Join me in welcoming Dr. Roberta Schwartz.
Well, thank you everybody for that incredibly warm invitation. This is quite a amazing series, and I'm only sad that I'm just learning about it. So, and an honor to be able to come here and join you today and share with you a little bit of the work that we are doing at Houston Methodist and really in that innovation community broadly in healthcare, and kind of stretch you and talk about some of the things that are kind of possible. And I do want to say as a caveat, you live in a very different community with different things where many things you got ahead of because of the rural nature of the community that you serve. And so some of this you may say, oh, we got ahead of that a long time ago. One of the things that we find is that even in unique areas where you do have a level of expertise, now the boundaries of what you can do with those areas that you are expert can be stretched pretty far. So I'm going to begin by sharing my screen. As soon as I do, I promise to blow it up into presentation mode, but it's easier to begin that sharing. And then We'll do the blow up. All right. Hopefully those slides are now shared with you, and we can begin. So one of the things that in the world of innovation that we've learned is that really it isn't about what you've done today. It's about who is going to leapfrog who, because in the world of innovation, there's constantly going to be those people who get leapfrogged. And if you don't really kind of understand that concept,
Why
think
can't I
of
see
the
the
fact.
people that are on, the participants?
Say that again.
Think of the fact that I learned Facebook, and I thought I was, far ahead of my children, who look at me and basically say, Facebook, like who would use Facebook anymore? I mean, Snapchat, Instagram, and those are being supplanted by other sites. So if you look at that and basically say it's going to be those that are adaptable to this change and really kind of move along this continuum of innovation and aren't afraid to do it. So our journey at Houston Methodist kind of started in that foundation, and the foundation being those bottom blocks, very clearly epic, and a robust electronic medical record. Very hard to do things without a robust electronic medical record, but also an innovation culture. We just are wired this way. It starts back in the days of Dr. DeBakey, who sews his own Descartes graft. And a strategic commitment to absolutely look at kind of where we're going from an infrastructure perspective, no matter whether or not the initial payback is amazing or not. On top of it, we start making piece by piece investments kind of into both a virtual and then actually backed into, kind of like Amazon, right, backed into a physical embodiment of our innovation, which is up on our 5th floor. I'll show you some pictures towards the end. But kind of piece by piece, we do view these as strong building blocks, some of which will take the shape of their own businesses and their own business lines in our future, and some of which will remain under either an operational hub or an innovation hub for the long term. But we are not, our innovation center is not separated from the hospital. It is not a separate infrastructure with a separate set of executives. All of us and major kind of players in the Center for Innovation, except a few, we hold a operational title and an innovation title. So my day job is running a 1,000-bed academic facility. My night job, because it's my passion job, is running our Center for Innovation. And really, if you look at our IT support, it works in much the same way. Our Center for Innovation really looks at what is a pipeline? What is everything out there? We do not build our own. We have a few areas where that's an exception, and I'll show you those. But for the most part, we recognize that there are a ton of startup companies, and they are doing incredible entrepreneurial work. And so what we want to do is partner with them to meet our objectives of running a better hospital and a better physician organization. That's our job, to run a better infrastructure. And we can do that with these amazing partnerships with these incredible companies. So we look at these companies and we basically say, what's it going to take to bring them in the organization? Sometimes we can pilot them in a swivel chair kind of way. Sometimes we can't. And it's just really all about integrating them into the organization. And then they either graduate and become part of our operational organization, or we call them rest in peace. And, these have a variety of terms. All of them, people say, oh, pick a better term, kill it off, end the project, rest in peace. Once we rest something in peace, we never kind of speak their name because we never want to speak ill of them. Maybe it was us. Maybe they didn't work well with us, but it really wasn't a fit for our organization. No, in every one of the contracts that we sign, we expect to be able to get out of that contract after a year, even though we'll do a contract as if they're going to be here for the long term. But that's kind of how we look at it. And so this is the chart of this is the punchline. I'm telling you the end story before I get into the details, because I'm really going to go into the details of some of these projects and the success that we've had and what we're doing. But this is the punchline. We look at a sheet like this all the time, and we're looking at what we're graduating, what we're piloting, what's in the pipeline, constantly changing that pipeline Once we do more soul searching on a product, we may realize that it should come out of the pipeline. Sometimes we rush it into pilot. Sometimes it will move to a different part of the organization, and we refuel this all the time. So quite honestly, like HDAI, that's really about to graduate. It may graduate almost out of pipeline and not stop. We've done a little bit of piloting, but we know already that that's going to be a graduate. Whereas pieces actually is interesting. They've got some pieces still back in pipeline and some in pilot. I think that may stay in pilot a while longer than we actually expected it to. So where I said that was the punchline, and I'm always happy to come back to that slide because people want to know details. Today, I'm going to take you through a variety of different details on those projects and really speak about where there is. And I know my goal is to leave at least a few minutes for questions at the end and the chat function, and I will get in there after I get through. But let's talk a little bit about virtual, and probably, you know, it's almost embarrassing to talk to a rural set of hospitals and a kind of that span an enormous geography about virtual, because there were a lot of hospitals that were way ahead of us in a virtual journey a long time before we began. Now, the difference that we recognize is that we're an academic facility, right? And our expertise is taking that academic medicine and that robust academic pieces of it and share that. So for example, I always joke with people, I don't have general orthopedic surgeons. There is no such thing in my facility. I've got the orthopedic surgeon that takes care of the pinky, and the one that takes care of the wrist, and the one that takes care of, you know, the elbow, from the elbow all the way to the mid-arm. So the question is, there are a million general orthopedic surgeons who want the expertise of what someone in our organization has to offer. And so we've recognized when building our virtual medicine that ours may look a little bit different than Mercy. It may look a little bit different than Intermountain because of what we want to build. So again, in that partnership mentality, where we began our journey was in partnering. So we partnered early on with Amwell. This is literally a month old, this slide, and now we've moved that partnership from Amwell to DexCare, which is a product that comes out of Providence up in the West Coast. And we immediately did, one of our first forays was virtual urgent care, virtual visits, MyChart, which will show you how it exploded during COVID. Everyone's did, right? It was kind of the wave of the future. But the right-hand side of the chart is where we view our future and where we really view. It's the virtual ICU that we partner with some physicians. We're building our own now. Virtual infectious disease, teleneurology, telestroke, telepsych, and you'll see some of the newest forays into whether it's genetic counseling, whether it's nutrition we're working on right now. We have a little piece of that, but we're building a much larger piece of it. And you can see our partners off to the right. One of the biggest partners that we did in particularly our virtual ICU, which really makes it unique, is that we partner with a new company called MIC, Medical Informatics Company, Sick Bay, and they built, they were brought in actually to hear the alarms from inside our ICU rooms to outside the rooms, because our new rooms are actually pretty big. But they actually have this amazing amount of material that they were pulling in from our machines and pulling in from our electronic medical records, as well as lab systems and other. And we actually built independent algorithms with MIC Sick Bay. Why that's important is that we didn't pay the price tag from Philips. And there are many companies that have built this with Philips, but we're thrilled with the infrastructure and the ability to develop our own sets of algorithms with MIC Sick Bay, and are seeing that. Caregility is our main provider. We used BidYO to get this some of the things up more quickly, but 100% of our ICU rooms around the system are up, and we can do it on a cart basis to support other organizations. So really robustly having built that. Our journey, actually, I feel like I lucked into our journey. Our journey actually was, we had put the last of the cameras in our academic medical center for our virtual ICU literally the week before our first COVID patient. We had not turned them on. We thought it would take 6 months. Obviously, we turned those on very quickly, but you can see some of the speed by which, because we had the infrastructure, this journey went up and really kind of ramped very quickly, and really we're thrilled to see how quickly this journey could take hold. You can see the size of some of the outpatient visits that we were able to see, both in our virtual urgent care, which even supports our monoclonal antibody program at this point in time, as well as COVID, some of the COVID response, as well as urgent care just to support the community. It's interesting to say, will Teladoc win? Will CVS or Walmart win? Will Amazon win? Or will the hospitals win that kind of battle for the patients coming in on the front end? And I keep saying, I'm not sure I care, because this is, for most people, this is kind of a little bit of a loss leader. They want to get those patients in the door in a new way, but this is not generally a money-making venture in and of itself. And so for a lot of companies, they may get in and then get out, because the question will be, is it worth it? Or they're going to have to partner with hospitals like ours to be that front door. What we did find is that it's incredibly variable. The usage after you kind of get through the initial, oh my gosh, COVID happened and everyone has to go online. When we really looked at it, some people took to it, look at cardiology, and some people didn't take to it. So what we found is that we're really going to have to do some work to get all specialties to understand the power of how they should be using virtual. So again, I'll use it if I have to, but when I fall back and I don't have to, when there's no dragon facing, fire in my in front of me, it's unclear whether or not what work we're going to have to do to get various different specialties to use virtual medicine. Now, that's a little bit different, as I said, than hospital to hospital. And when we look at what we're able to service and what we're able to kind of help people with and get help for, it really is amazing to see the growth of the hospital business. And I actually think that there's very little limit to where this will go. And that's why I'm going to show you some of the important of the infrastructure that we put in our rooms to support a growth of the amount of people that we think will want to do virtual medicine within the hospital setting. The rollout of our virtual ICU was incredible. As I said, you can see that date, March 2020. Who knew? Who knew? We began our journey 3 years ago and just literally happened to hit the date of March 2020 with the last of the video cameras and all the technology being put in the room. Obviously, we made very good use of it, but then we rushed to get it out around our system, and the Center for Innovation supported it. This is our virtual center. These are our virtual RNs that are here. We just looked at actually doubling. I got back two minutes before this began from one of our other campuses, looking at a very large space to support our virtual and remote monitoring, as well as hospital at home, and kind of building off this infrastructure that we built. This is our Telestroke program, and really looking at those consults and the way that program has grown for our systems. And now we're finally ready to support outside hospitals. It's now very mature in its base. One of the things that I think is unique is now what we've done is we take those programs that are now mature and we turn back around and again say, what are the other uses for those programs? So what else can we do with them? So with our behavioral health, one of the things we said was, let's turn that inward and support our primary care base in a collaborative care fashion, because they can't get enough support from psychiatry. There just aren't enough psychiatrists that grow on trees and take insurance. That's been in a lot of papers lately. And so how can we, in this foundational model, support people? And so that behavioral health system turned around to support our primary care in a very new way. And you can see on the right-hand side kind of how that works. So the primary care model kind of talks up to a consultant. who kind of gives off some directives to social work, who then supports the primary care doctor, and kind of they have this collaboration. It's actually billed by the primary care doctor, and then supported over to the collaborative that supports him and gets much quicker response for particularly elderly patients that may have some needs on depression, anxiety, and other areas, and can get that very quickly through our primary care. Excuse me. We piloted this and we're able, as you can see, to really do some amazing work on depression screening and anxiety screening. And I can tell you that one of the most amazing parts for me was when one of these primary care doctors actually said, I am actually going to donate philanthropically to this program because I've seen so much value to my patients. So when a doctor then turns around and says, I'm going to support this, you know that it's something they truly believe in. Genetic counseling is actually another area that I am bullish on the uses of this. For those of you who are a genetic counselor, work with genetic counselors, I used to think there was one, right? I'm a genetic counselor, I'm hiring a genetic counselor, but no, there really isn't. There's the same level of genetic counselor expertise that there is among doctors. So I'm a genetic counselor for pediatrics. I'm a genetic counselor for cardiac. I'm a genetic counselor for cancer. So when we did it, you kind of need 10 or 20% of multiple different genetic counselors. And so really to get that level of expertise all across our system, we partnered with a company called Genome, who does offer that genetic counseling. So a doc can call up and say, my patient needs genetic counseling, and they take it from there up to and including organizing the testing. So it was really important to be able to bring that to our primary care doctors and to our specialists who may want to access it. When I said I was going to come back to virtual medicine and the importance, one of the foundational projects that we did was tablets, and tablets in every room. And I can tell you, my first reaction to tablets in the room was, no, I don't want to deal with tablets, and I don't want to deal with infrastructure. All the patients have their own phone. They can just bring their phone and I'll put the software on their phone. And what we found really after talking actually to Darren Dworkin, who was at Cedars-Sinai, is that there was an incredible value to having a tablet that has the same icons everywhere in our system, and that our nurses know exactly where everything is, so that they didn't have to search on somebody's home phone and figure out how to tell them where to get to our different applications. It was really important that we really have this standardized way. I was worried about loss, but it's really a very, very few iPads get lost. More, it's the cords. We really had to work actually with our 3D printer to create cords that don't get stolen, because most of them disappeared in the first week and we really had to change out our system. But now what happened once we layered on this infrastructure piece is that we are now layering on important pieces on the iPad to support our future endeavors, current endeavors and future endeavors. So for example, one of the things that's on the iPad is translation. It's on every iPad. It's always in the room and there's an app for it. A second one is education videos, spiritual care. They have a whole library for spiritual care that's loaded onto the iPad. And what I said I would come back to, which is Caregility. And so Caregility is going to give the ability for any doctor to beam into the room and do a telemedicine. So no matter what we load at the other end, whether it's genetic counseling or behavioral health, or whether it's a light ICU type of approach, or just a second set of nursing eyes, or whether the family want to beam in their family members for a family conference when the patient is in the room and when the doctor finally arrives. And that's inevitably when the family goes downstairs to get something from the cafeteria. Those are all loaded onto these iPads. And so each month I see more and more people clamoring to get their app and their unique spin on what they want loaded onto the iPad. But the infrastructure's there, and so loading it is very easy. These are kinds of things that we have. We have Caregility, as I said. MyChart Bedside was another important feature for this. Customized patient guides. And it does have a manual data wipe. When people, before they leave the room, they want to wipe it. It also automatically does a wipe with a company called JAMF as soon as the patient is discharged from our system. We supported this through some foundational gifts. It also, you know, you can enjoy, of course, there's no doubt it has entertainment and information on it, but also just infrastructure wise, it was something we wanted to support. This is not the only tool we put in the room. We were bullish on putting Alexa devices in our rooms. So each one of our room has a dot in the room. The goal is, and hopefully shortly, within 2 months, I think, these will all be hooked up to Nurse Call. So a patient can just say, hey, nurse, I need my pain meds, rather than pressing that button and having it go. It'll go directly to the nurse's Vocera badge, and they can talk back to the patient through the Alexa device. And so when we look at how it's being used today, heavily for music, but that's not the, sorry, as I began speaking with my device, of course it turns on. I should have muted it before. We do get a couple of questions. Oh my God, it's listening all the time. You can mute this, or a few patients have asked us to take them out of the room, very few. This is a HIPAA compliant device, which allows us to really look at different uses and different skills. We also are doing, one of our campuses is piloting pharmacy teaching through the device. Care pathways, as I alluded, this, if there's one home run that we had, and without a doubt, it would be our care pathway program. I'll show you another one, which would be called intelligent locations. So what this is it's crazy in that we basically went with doctors and we said, what is the care pathway for a patient who's getting, let's say, knee surgery, before they come to the hospital and after they leave the hospital? We leave the hospitalization alone for the moment, but again, now with the iPads in the room, we can go back to that as well. But we said, what are the things they need to know on each day? And then after they leave, what are the things that they call us about? And our goal is to text them bite-sized pieces of information with, if they want, embedded videos or embedded kind of forms they have to fill out. You can have one-way education. I'm going to tell you that it's the night before your surgery, take your CHG bath now. Or two-way communication. It is the day after your surgery, please report in your pain level. One-way education kind of gives you the information. Two-way says, oh my gosh, their pain level is a 10 the day after surgery. I need to call them because something's wrong. One-way or two-way. The amazing part is the results on the left. 98% patient satisfaction. Look at the reduction of readmissions, patient engagement with these texts, reduction of length of stay, and for our doctors, the reduction of emails and calls to their offices. So when we really look at this, it's incredible to see how simple texts, like ridiculous small little texts dropped into your text box on your phone, have fundamentally changed the way that we work with patients. And we have seen these results replicated in condition after condition after condition after condition. I actually saw one that was an outlier. It's actually our TAVR procedure, where this is not true. Our CareSense patients are actually higher, in some cases, length of stay than our non-CareSense pathway patients. But these results replicated again and again and again and again. And it was so successful that we actually decided to use this as our pathway, our platform for COVID and all communication with patients who were, after they went home from even the emergency room with COVID, to keep in touch with them, right? The goal is to be a little creepy, give you answers before you need them. And people literally reported in that they felt like they weren't alone, that someone was there with them, that they had somebody watching their back. And it's an automated set of texts, right? There are people behind it if you text back, but really it was amazing to see the amount of people that we were able to keep in touch with through this. When we found out, one of the questions was how many people would want text, how many people would want email. So people can report in, I want a text, I want a phone, or I want an email. And then what we found is that we could actually update and make sure that we had the right way to communicate with them. And you can see we're now actually, again, that's a little bit old. This says 75 pathways. We're well over 100 pathways at this point. And we're not stopping. Everybody around the organization recognizes the importance of this. And one of my favorite conversations was one physician was presenting to a room filled, our medical executive, and was presenting the value of this. And the physician next to him said, why would I take the time to build out the pathways for somebody else? And the guy next to him just turned and said, did you not hear? Did you not listen to 40% reduction of phone calls to your office? Would you not want a 40% reduction in phone calls? And I was like, well, if one physician's going to tell another physician basically why they should do this technology, I'm done. As successful as it's going to be. We then, from this, you're now going to see a few other technologies that kind of spoke to, okay, actually, we could speak to our patients through automation and actually have pretty astounding results. So this is phone. This is something called Syllable. And we learned about this technology through New York Presbyterian. And it's a guy who came from Google. And his answer was, I can use natural language processing to listen to where you want to go. So it used to be that I pick up my phone here, dial 0, ask for a department, dial 0, ask for a patient. Now, basically, I dial 0 and I get the Syllable bot. And quite honestly, it works unbelievably well. I get connected and I don't have to pay for operators. And what we're finding on our main lines and the key things, our patients are happier and get to the right place more often. Scary enough. It was really hard with a series of operators to actually figure out how to get to a cardiology calcium scoring test. Now I just pick up the phone and say cardiac calcium scoring test, and it gets me to the right office. So you can see how many calls now we are handling through automation. The COVID vaccine in December and January would have taken and crashed all of our phone lines. We went up on Syllable within 10 days to make sure that we did not crash our phone systems and were able to really use this. Now, Syllable may actually collect your cell phone number and send you across a link to schedule so that you can schedule, you call in, say, here's what I want, and we'll send you a link to schedule this for yourself, an appointment for yourself. It's really, we're starting to link these technologies. Another texting technology that has been incredibly successful is something called Well. And what Well does is it serves up, the kind of, I'll say in a minute where it's getting the appointments from. But what it does is through a text to a patient, it serves up the information. Hey, I want to give you a reminder. Did you want to keep your appointment? Do you want to cancel it? And it's interesting, you can, in a lot of places, all you can do is press 1 to cancel, press 2, right? And it gives you something back. No, ours is actually open texting. So we have people who will text back with you. So if you basically said, hey, I need to cancel my appointment, and you just write it in the field, a person will write back and say, hey, that's okay. When would you like to reschedule that for? Patients, this comes actually from Blockit, which is an underlying scheduling technology that is outside of MyChart, makes it easy for non-MyChart users. And for people who don't know what I'm talking about with MyChart, it's the Epic. There's really 2 major EMRs, right? Epic and Cerner are the 2 big ones. And they have their own proprietary, for people who log into it, ability to get all of your results. But most people don't know that and don't use it. 70% of patients don't link into MyChart. So you need to be able to talk with them in their current text. They just want this stuff to arrive on their phone in their open text box. They don't want to have to go into an app to schedule something. So right now, all of what you're seeing goes into a regular text, and it is very HIPAA compliant and very protected. So when you text, what happens is that you get these incredible conversations with your patients. And the patients will say, hey, while I'm there, can you organize it? I'm going to need these prescriptions done, and I'm going to need this other appointment. And so we have these robust text experiences with our patients that has changed from phone to text. And then, as you can see, we keep getting more robust about what we're offering up to patients so they don't even have to ask for it. Well now can serve up that you can just reschedule and it'll pop up a new schedule. And it comes from something to the right called Blockit. And Blockit is a very easy user interface to basically say, hey, I want to schedule an appointment. Oh, I'd like the 8:15, 9:15. And so this was a much more user-friendly scheduling approach than Epic, which is a key one. So confirm your appointment. Nope, rescheduled. Oh, it's rescheduled for you. The whole goal is I don't want to build a better call center. I want to get rid of the call center. So what do I have to do to move you somewhere? I think someone said it beautifully in a conversation I was in. Do you want to walk up to a teller at a bank or a bank machine, an ATM, and then basically press the button and have the teller from inside the bank come out to you, and look at you in the face? No, you don't care. You just want to get your money. For you, most people just want to schedule their appointments and get out of there. We were able to keep up with an incredible capacity when it came to the work we did with our COVID vaccine sites. And all of this through the technology that you've just seen. When I said that there was something that was, we broke the rule on, it was voice. And the rule is that we partner, except kind of in voice. The voice technology sites are really just not that good. And we know that our doctors don't want to be clicking and typing and doing all kinds of things. And so one of the most important things that we wanted to do was give the option to go back to voice, having a conversation and having it collected. And so one of the things that we've are working on, and we are doing this in partnership with Amazon. We have a beautiful partnership with them, is to the left, it's called voice commands. So if our doctors go into the operating room, they could say, open timeout sheet, and it opens it, it listens, and they can just talk to it, and it fills it out in the discrete right fields. The right-hand side, we've been working with them on a doctor and a patient actually sitting, having a conversation. It pulls out key pieces of information, populates the electronic medical record, and populates a note that the doctor can sign off before they leave the room, thereby reducing burnout and getting their notes closed before they leave. So if you see, these were key things, and we have been working on them closely, and they are starting to bear fruit. So you can see the active listening, passive listening, and being able to do things like, I'm almost afraid to say it, it'll turn up, hey Siri, tell me directions, as I did in the car today. And now she's coming up on all of my devices. So it's the same concept. And we knew that Amazon was incredible in the field of voice, and we wanted to work with them. So we've had this in our tech hub, and one of the pictures of our tech hub is to the right. This is Dr. Desai, who was our Chief Medical Information Officer, has now become a Chief Quality Officer, and he is a doctor, so he is able to work with this. And you can see he's having a conversation with a patient, and behind him, that note is populating on the board. So impressive, and these little discs kind of collect that information. This is our OR, and so you can see basically all of the checklists that we need are all done through voice commands. So both of these are in trial right now. We're thrilled with how quickly they are developing, and it's great. As I kind of wind down on a couple of other things that may not be as sexy, but are really amazing. Obviously, everybody is changing to remote work tools, so are we. We've just taken these a step further into every one of our clinical environments, and they really working on the workforce of the future and what's going to power that. But what we've thought about is how we can use all of these workforce tools to kind of source our talent. And for all of you who are not following, healthcare is certainly going through its challenges in terms of that workforce and the transformed experience. And these are all the tools that we have taken from each one of the things that you say and turned them towards our recruiting process. So you can see, Alexa, find me a job. If you want to do that, you can find your job at Houston Methodist. We have iSIMS. We have a new way. We call it the Domino's Pizza Tracker of applicant tracking, and that's quickly rolling itself out, because if Domino's can do it, you should be able to know where your application is and where you are in the process of interviewing or getting an offer. We have are working with Livongo on diabetes for our population, symptom trackers with something called Buoy, and up to the upper left is a bot called Mia. She goes out, if you look looking for jobs in Texas, she will come out and she can take you all the way through on nursing and many other jobs, all the way through screening to the point of getting your interview scheduled, all without talking to a human being. And that these tools, again, everything what I said, we turn these tools and basically say, tell me everywhere they can be used. Oh, we're using CareSense with the patients for care pathways. What's the difference of a care pathway and our employees that need to have a 30, 60, 90-day review? Why can't we use CareSense in our employee population? Oh, we're doing work with Alexa. Let's turn that towards applicant tracking. We'll take iSIMS and we'll say, what else could go on a Domino's pizza tracker? Hey, iSIMS, can you help us build this? And we love working with companies in that way. We turned all of our orientation virtual, and I can tell you there's no going back. All of our first day of orientation. One of the most amazing things, though, was we lost no ground in people being satisfied with our orientation once we went to online. And we continue to innovate in kind of HR and the work that we're doing there. I do want to talk about one other thing, which is a dear love of mine, which again, a very robust, lovely innovation that we did, which is something called intelligent locations. So our goal here is to track, and I'm not allowed to say it exactly this way, but you'll understand it the best, people, places, and things. Right? So if you have a tile on your keys because you are exactly like me and you lose them all the time in the house, then basically think of our hospital environment. We wanted people to be able to find their way. We wanted to find our people. If it were up to me, I'd stick one of those tiles in a doctor's, lab coats. We knew where they were going and what they were doing, but we really wanted to look at hand hygiene compliance, environmental, and we wanted foundational product. And we really did that work with intelligent locations. The return on investment was almost immediate. It was cheaper than the way that we were tracking our temperatures right from the get-go. And so it actually was cheaper than the other product, yet it has all of these capabilities. And I can tell you, people are fighting to get first, second, and third with intelligent locations. I think telemetry may have won with telemetry monitors, but looking at transport times, response times, everything, it was really amazing how quickly this is taken. And these are some of the reports that we're doing. You can also see all of the different little tools. It's a sticker, it's a card. You can do it in a variety of ways. I'll finish up kind of looking at our technology hub, and we do have a virtual tour. You can get onto Houston Methodist site, but this is kind of that view as we look at the capabilities. Most things get tested out in this conference room or one of our rooms of the future, a home room of the future, a living room of the future, a clinic room of the future, or a hospital room of the future. We test out lots of different innovations within those rooms. I do want to tell you and give you an eye that we are always looking at the future. And so whereas I don't feel very comfortable kind of outlining all of our strategic vision, because that's some of our secret sauce, one of the things that we are doing currently is looking at every trend that we think will shape our future, whether it's hospital at home, remote monitoring, whether it's telemedicine, or whether it is text and what they're doing there. We look at the companies that we think are out there, and then we look at the infrastructure that we think will be needed. And we are closely aligned, like literally hand in glove aligned with our IT partners to make sure that basically we are in line. They are working on cybersecurity in, I keep telling them, in very different ways, because I'm going to have devices all over somebody's home, and those are going to link to my systems. Well, that cybersecurity looks a little different than if you're just worrying about it for within the walls of your hospital. So we work with them kind of in that seamless way to make sure that we're building for the future. And this gives you an example of like a telemedicine and kind of what we're looking at. And if Kaiser has 65% of their visits on there, Why do I only have 30%? And what is it going to take? Is it important? Is it not important? And who are my partners? So we always say luck happens when when preparation meets opportunity. COVID was a lot of that for a lot of us, but quite honestly, there is so much opportunity. And so we are taking that preparation side and looking at the opportunity and just seizing the day. And again, that's the beautiful part of just making sure that this is a passion for all of us and not just a job. So I hope that gives you a little bit of insight, and I'm happy to kind of work my way through so some Q&A or some chat, however you would like to handle it, Dr. Friedlander.
Thank you very much, Dr. Schwartz. Fascinating. Yeah, there are a few questions, so I'll go ahead and kind of moderate for you and read them out. So Dr. Paul Skolnick, who's chair of our Department of Medicine at Fralin Clinic and the Virginia Tech Fralin School of Medicine, said, how do you staff the various services with physicians? For example, teleneurology. Do you hire additional physicians within Methodist, ask existing physicians to do more, contract out to external physicians, specialty companies, other?
The answer to that is yes, all of the above. So it's really interesting in that some of these we had our own. So teleneurology happened to be one where our internal physicians at the academic center had a passion for it. And so we've been backfilling those and adding on some additional capacity. We hired on 2 additional people and then serviced all the other people, the hospitals, with kind of our people. Now, a few out in the community wanted to be a part of that call service, and we said, absolutely. Some of our hospitals buy 724, and some of our hospitals just buy that night coverage. So it's really interesting. We're now looking, as we look to the future and look to selling that, we're actually looking at hiring some neuro hospitalists here at the main academic campus so that those individuals can further stretch themselves out into servicing a wider array. But on telepsychiatry, we don't. Houston is terrible, terrible. In terms of having psychiatrists. In that case, we did some contracting. And in virtual ICU, it's a combination. It is a little bit more contracted, but it will become half internal. My guess is half contracted. So each of those are growing in different ways. But we believe the answer to that is yes. And you should look at, actually, interestingly, New York City has an overabundance of ICU physicians. Not probably during COVID, but all other times they actually are one of the few cities that overproduces them. So why shouldn't I look there? Or time zones. We're looking at a company in Israel, I believe, right now.
Good, thank you. And as a follow-on, not to be redundant here, but Dr. Marcus Speaker, a family medicine physician, who's also Associate Chief Medical Information Officer. First of all, he said amazing work. And he asked about your staffing model. You just told us something about that, but he went on to ask, how many FTEs are required to keep the lights on, feed and maintain the current system, and put these new systems in place?
So all of us, again, the Center for Innovation, there are 4 FTEs in the Center for Innovation. The rest of us all have day jobs. And most of us, it wasn't really, a few people, there may have been a little bit of extra money that was put in, but most of us, that wasn't the reason we were doing it. We really believe that this is fundamentally going to change healthcare, and we wanted to be a part of it. So when we look at the amount of money we spend, we do have about started out as $2 million. I think we're up to about $6 million now. Because people have asked us to do a lot of projects, and that's about per year. Once we graduate a project, we anticipate that it has some type of return on investment. Either the institution has decided it is so successful that they are willing to pay for it. Example would be CareSense. CareSense has a cost to it, but in every service line, it reduces length of stay, reduces readmission. So every hospital was willing to put up the money to pay for the ongoing cost of CareSense. Intelligent locations, that was easy, right? That project, we get it off the ground. We pay the roll the ball uphill costs. But once intelligent locations was put in and implemented, right away we traded off temperature monitoring costs, and it pays for CareSense. So our budget is to kind of continue to push this ball uphill. We paid for the iPads. Now there's really no cost of the iPads. There's a small loss cost, but it's the ongoing, it's what people put on them. And there is somebody from IT that is now assigned to continue to put things on them. So again, things move into various parts of our organization, but a lot of times it's replacing something that we already had.
Thank you. Dr. Anthony Lamontia, who is, leads our brain research neurobiology unit here at the Research Institute, asked, is the goal of these technologies to provide better patient care for the current population served by the hospital and the region from which additional patients are referred, or is this linked to development of commercial branding? So telemedicine and digital support delivered with the brand of Methodist or the Cleveland Clinic or Hopkins, whatever, will be claiming exclusive digital access to networks of physicians anywhere in the country, a kind of wild west of digital medicine.
Yeah, right now our strategy is to support, we are, right, fourth largest city in the country. We have a lot of work just to do to support our own community. And at this point in time, we're very focused on our own community. And it's the community that we are looking at digital medicine combined with in-person medicine. So one is supportive of the other. I don't think that we are looking right now at a strategy that is like, hey, we are Houston Methodist, come to us for your digital medicine services. We do have a second opinion program. It's not very large. There are other people who have much larger programs like that. But it's a little bit of a different strategy, and that's kind of that secret sauce of what are we looking to support. So where we're going to go to support the expansion of our virtual medicine programs are hospitals that we work with routinely that send patients to us that we think we can help them keep more of these patients in their community, and or send the right patients to us or optimize them before they get to us. So that's really what we're looking, even supporting 8 hospitals and doing it right and being able to support people who may not be able to get a dermatologist to their hospital in one of our 8 systems at the right time of night. That's our initial goal. So where we go from there, I don't know, but we are taking a different approach than I would tell you Mayo or Cleveland Clinic.
Okay, thank you. Dr. Susie Kramer, a physician, internal medicine physician here, said, you have an uptake of your numerous applications across generations and demographic groups.
When I said that 80% for something like CareSense or interacting, I can tell you it's 80% across all of the age groups. It's amazing to us. It's interesting that we met with ZocDoc, who's one of our partners that is has our appointments on one of their sites. And what they found is that in underserved communities, they'll make an appointment by their phone, and in slightly upper class areas, they will make an appointment on their computer. And so the elderly are more likely to do it actually on an iPad type of technology. So what we've done is kind of say, what works for you? Is it the phone? Is it email? And if we give people a variety of things, and I do see this question in there, is the voice command responsive to various languages? Right now, heavily we're based in English, but we are looking at a company called Consejo Sano that is culturally responsive both in language and the way they work with people to see whether or not that can be additive to us. And it's not just it's not just the language, it's the cultural sensitivity and doing it in a way that culture will best interact with us. Again, our goal is not to build a better call center. It's to eliminate and get rid of as much as we can of the call center. And that means getting people to do things on their devices. But given the fact that almost everybody has figured out how to use Amazon, and if you try to find a phone number to call Amazon, it's really hard to do. People have figured this out, and that's our goal.
All right, thank you. Donald Littlepage, the Senior VP for Accountable Care Strategies at Trillion, asked, you've looked at using tablets in the ambulatory setting or as part of remote patient monitoring?
Yeah, so we have a partnership with a company called TytoCare. It's a company out of Israel that basically has a variety. It's a large clinic model and a small wish I had it here. I'm sorry, I could try to pull up pictures, but if you look it up, it's called Care, and it has a pulmonary, it's working on an abdominal, it's working, it has, I believe it's pulse ox, it can look in the ears, it can do temperature screening, it can look in the throat. And so we've been working with them on how to build out a robust kit that can give us a lot of information. In addition to that, we one of the issues that you've got in remote monitoring is there are like 100 companies. I mean, it's unbelievable. Oh, this one will do the heart, and this one will do the finger, and this one will do the arm, and this one will do the dementia, and this one will do the falls. We're trying to look at companies, as you've seen, that have a foundational set that we can help build things out with, that can not just do one area of the body, but can help us remote monitor multiple things. And that's been a challenge for us. So remote monitoring is a big thing for 2022 that we are aiming to figure out in a much better way. But for now, our partnership is with Care.
Okay, thank you. And Troy Kaiser, the Director of Innovation at Trillium Clinic, said, thank you very much, enjoyed the talk. He wondered how transferable these projects are to other health systems, or are they very locked into the Methodist structure?
One of the beauties of doing partnerships rather than ownership is that these are companies that are out there. If you'd like introductions to any of these companies, you're fascinated by what we're doing, we'll be happy to make introductions. We do not, at this point in time, have investments in any of them. So anything I would be telling you is out of love and true belief in their value, and not because, you know, it's our something or other. We're talking about making one of our first investments, but it's taken us a while. I can tell you, I am, everything I'm showing you is, we truly believe are things that will add value for just about everybody.
All right, thank you. And if you don't mind, I'm going to take the liberty of asking the last question. So as a researcher myself, I can't resist asking you about some of the things we saw that are fascinating from a researcher's perspective, and whether that's a researcher who's looking at the data coming from patients, or a kind of a health implementation science researcher doing research on healthcare delivery, the system, et cetera. How amenable are these things to providing good, usable data in an easy way to the research community?
So I can tell you, I encourage it all the time. When I sit with our doctors, I basically, I say to them, you know, it's amazing that the interventions we've had within CareSense are actually better than many of your pharmaceutical products. Why aren't you publishing on it? We hand them the data. We literally do the analysis, hand them the data, and just say, write it up. You did it. You used it. Your patients used it. MIC Sickbay has unbelievable amounts of data in it. And one of our physicians is working on pulmonary and kind of ARDS, and basically, can you be predictive of it? And can you build an algorithm there? A lot of these companies have incredible data scientists, something that a lot of us can't really afford. Huge amounts of data scientists. They're very expensive and they're very difficult to find. And so we encourage people to basically say, this is a field in and of itself. We do have somebody from our Center for Outcomes Research sitting on what we call our DIOP, Digital Innovation Obsessed People. That's our steering committee. It got that way because we had a meeting. We didn't know what to call it at the very beginning, and I called it DIOP, and it stuck. So he sits on our DIOP to actually listen and say, oh, that might be something interesting for a project. And so all of these technologies and all of the results are fully available to all of our physicians to basically pick up and publish. We do have, I think, one PCORI grant and a few other grants that have come about because of the technologies that we have.
That's great. Well, Dr. Schwartz, really want to thank you. It was great, stimulating talk. Everybody, please join me in thanking Dr. Schwartz for a fantastic talk. Really appreciate it. And thanks for attending. And Roberta, I'll see you in about a half hour again. Okay. Thank you. Thanks, everybody, for attending.
Thank you.
Bye-bye.